Metabolism refers to the set of life-sustaining chemical reactions that occur inside a living organism. In medicine and anesthesia, we generally use metabolism to talk about the breakdown or change in chemical structure of the drugs that we give. Now, most commonly, we talk about how drugs are broken down in order to be excreted from the body, but it also refers to how prodrugs are metabolized to their active form to then have a clinical effect. The vast majority of metabolism happens in the endoplasmic reticulum of the liver, but it also occurs in the kidney, lungs, blood, and other organs around the body to a lesser extent. And it is generally divided into two phases. Phase 1 is what we refer to as a non-synthetic phase, and it's designed to inactivate the drug, and the vast majority of drugs undergo some form of phase 1 metabolism. And some examples of these are hydrolysis, oxidation, and reduction, usually facilitated in the liver or catalyzed by the CYP450 enzymes. Now, different enzymes responsible for metabolizing different drugs, and you can see some examples here. There are way more than this, and you don't need to know all of these at all, but the ones to be aware of that get examined are 2D6 does codeine, 2E1 does your sevoflurane and your isoflurane. These sometimes get examined, the vast majority don't, but it's just to be aware there are lots of different enzymes for lots of different drugs. Some other specific examples of phase 1 reactions you might be expected to know are catecholamines, such as adrenaline, noradrenaline, dopamine, are metabolized by monoamine oxidase. Atracurium undergoes Hofmann degradation and ester hydrolysis in the plasma. Succinylmethonium is hydrolyzed by non-specific esterases, and then maybe ACE inhibitors are metabolized in the lungs. These are the examinable ones that tend to come up. I wouldn't bother learning any more than this. It's just appreciating that phase 1, the vast majority of drugs undergo, and it tends to be something like hydrolysis, oxidation, and reduction, and it is a non-synthetic inactivation of the drug. Now, phase 2 is a synthetic phase, and its main role is to increase water solubility to make it easier to get rid of the drug in urine or in bile. Now, some drugs only undergo phase 2, or mainly undergo phase 2, such as lorazepam. And the reason this is clinically important is if you have liver failure tends to affect phase 1 to a greater extent than phase 2. So if you have a drug that is primarily phase 2 metabolized, it's going to be less affected in severe liver failure than a drug that relies heavily on phase 1 inactivation. And the examples that you need to know of phase 2 metabolism are glucuronidation, acetylation, methylation, and sulfation. And you can see by the names, these generally involve adding a functional group to a molecule that will then increase its water solubility, whereas these tend to be just breaking specific bonds to stop the molecule from working. And just for some examples, morphine and propofol undergo glucuronidation, isoniazid undergoes acetylation, noradrenaline gets methylated, and propofol also undergoes sulfation. If you can explain this concept in your exam, you will more than likely absolutely pass with ease. The key thing is understanding there are two separate processes. They can occur at different places in the body. The vast majority of this phase 1 metabolism happens in the liver, and so any drugs that are heavily reliant on this process are disproportionately affected in liver failure. It's also useful to appreciate that you've got the same enzymes doing different drugs. So you can have interactions between these drugs. If you're giving a lot of one drug and the enzymes involved are busy managing that drug, it can affect the plasma concentrations of another one in the same group. Really common follow-up question is asking specifically about codeine. Codeine is mainly metabolized by CYP2D6, as we mentioned here, but also by CYP2C9. And what's interesting about codeine is metabolism of codeine is subject to genetic polymorphism, which means you can be born with a genetic variation in your enzyme that means you process codeine very differently, and this is why some people don't respond at all to codeine and other people are very, very sensitive to it. Codeine is a prodrug, and as we mentioned here, that means it needs to be metabolized into morphine for it to do anything. So if you don't have the right enzyme, or your enzyme doesn't work very well, you will not produce that morphine, and therefore you won't get the analgesic effect. And by percentage of the population, 80% are what we call extensive metabolizers and get decent analgesic effect from it. 10% are poor metabolizers and therefore don't feel much benefit at all. Then 5% are intermediate, and 2% are what we call ultra-rapid metabolizers, meaning they get a very rapid onset of a high plasma concentration of morphine and are therefore quite sensitive to it. And the CYP2D6 enzymes also metabolize oxycodone, methadone, tramadol, and some SSRIs. So you'll find that patients that don't get on with codeine often have issues with these drugs as well. And that's an intro to metabolism that should get you through at least 1 or 2 OSCE stations in the FRCA primary exam. Now, everything you've just heard is in our primary toolkit, and you can see all of the information we've discussed is easily available with diagrams and hyperlinks to other resources. So we'd highly recommend, if you're revising for the exam, to check out our primary FRCA toolkit.